Good day, everybody. Dr. Robert McNutt posting a video today regarding a clinical trial study design. Yesterday, I posted a critical appraisal of a study that was published in the New England Journal of Medicine regarding the use of a drug called Remdesivir in people who were hospitalized with COVID-19. Now, that trial was a randomized controlled trial. And a randomized controlled trial is considered the gold standard or the best way to study any kind of intervention for our care. Now, realize that what that means is that we have to, all clinical studies and all medical decision-making is based on a comparison. It's a comparison of option A versus option B. Option A might be better in terms of the disease that we may have, but oftentimes the option that is better for us from the disease perspective also can cause more harm through side effects and complications. Medical decision-making is a balancing of the benefit and harms of interventions proposed to us. But those interventions must be tested in the best ways so that we can be assured that there is an independent contribution of what we are studying to the benefit of that therapy. Now, what does that mean? That means that there's a lot of reasons, because humans are complex, while some people may do better than others under various circumstances. I think you're all aware of what people call observational trials. For instance, instead of stepping back for a minute, away from randomized trials, we find that often people do better taking one thing versus another. A long time ago, we looked at women who took estrogens, and they seemed to do better in terms of heart disease. And we thought that was really cool, and so we started giving all kinds of women estrogen. You see it in the lay press all the time. Most recent one I saw was about wine drinking. If you drink one glass of wine a day, it is good for your health. Now, these things are not possible to be told whether they are true or not. The reason is because they're observational trials. We're watching somebody who does something like take an estrogen or drink wine, and we're comparing them to people who do not. But what we can't control for is that the people that take the estrogens or took the wine could be very different on characteristics that affect the benefit outcome that you can't control for in an observational trial. So that's why we do a randomized controlled trial. But that means that we take people eligible to be studied to test whether or not they should get a treatment A or treatment B, and we then randomize them to the treatment plan so that the balancing of the factors that may affect the outcome, other than the treatment being tested in the research study, that is, can be balanced enough so that we can find the independent contribution of the thing we want to study. Now, to do a randomized trial takes a lot of work. You have to have eligible patients. You have to pick them in a pristine manner. You have to have a very clear outcome to be measured. You have to have a very good sense of how much better you want your new drug or your new therapy to be. That's important because you have to make some decisions about how many patients it would take to be able to prove one way or the other that treatment A is better than treatment B. You have to limit other therapies that are associated with the disease, and because you want to find that independent contribution during the comparison. And then you have to interpret and make sure that everything is balanced by the end of the trial and make some kind of a statistical comparison to see if one therapy actually is better than another. Now, in the Remdesivir trial, I pointed out that there were errors, in my view, in the conduct of the trial. Number one, we don't know where the patients came from. We don't know how they were chosen for this study. We don't know if they were randomly picked or consecutively picked. Therefore, we don't know if the population being chosen for this study is actually going to be anywhere close to any other population we may use the drug in. This is a concept called generalizability, and right up front, there is a concern with whether these findings in this randomized trial of this remdesivir as an example, could be but in any treatment though, that whether or not we could actually move it and generalize whatever we find within the study to those people outside the study. On the other hand, once you also have to know that what am I trying to get better? Do I want to save life? Do I want to save function? So in this trial, they wanted a very complex outcome measure, and that outcome measure had judgments associated with it. Whenever there's judgments associated with an outcome measure, that outcome measure is not easily measured, and there's going to be a lot of error rate in the measurement. So right off the bat, we didn't know they had a generalizable study. They had a very complex outcome measure with judgment involved. The next thing you want to do is that you want to make sure that you plan for when do you want to stop the study. How much better is something going to be? And you have to follow that plan throughout the entire trial. In the remdesivir trial, they didn't do that. They actually changed the outcome measure halfway through the trial, nearly halfway through the trial, and they stopped it early in the trial because they saw a benefit. But that's not the way trials are supposed to be done. They're supposed to be planned, carried out to fruition, and then interpretation is supposed to be made. Another part about randomized trials is, as I said, one of the best things about a randomized trial is that everybody's getting a single treatment and only a single treatment. But the other thing is that there has to be a balancing of factors that may contribute to the outcome other than the drug involved. Now, you think that should happen in a randomized trial, but it often does not. And in the remdesivir study, in my view, there was imbalances in important prognostic factors that could have made one arm of the study, in this case the drug, better than it actually is. And that imbalance in those factors has to be accounted for and measured. And I showed a way in that last post about how I go about doing it, comparing within the trial those cofactors or confounding factors that come with the persons involved in the study to see if they affect possibly what the drug benefit would be. And I thought there were significant imbalances. I also do think that a trial should be conducted from people who have no financial interest or no conflict of interest at all in the outcome of the study. The best researchers don't care how their studies return or what they return, whether things better or not. They just care that it's done well, and so we can learn and see if there's an independent contribution of a treatment or not. So I hope this kind of general summary helps you think through clinical trials. In my site, I try to go through the best studies I possibly can. As you'll see in the blog that I did before, I could not advise the patient from my perspective on whether or not remdesivir was better for her should she need it, and I told her why. She'll make a decision based on that after discussing it with her physician, but I thought that there was concerns enough in the study that it was hard to estimate whether benefit really occurred from that drug. So those are general senses about how do you do clinical trials. While this was an important example, if I was still teaching evidence-based medicine, I would use this trial on remdesivir as a way of maybe not doing trials rather than how to do trials. They can be very hard to do. I think there was problems with that. But the most important learning point for you is you have to learn to be sophisticated enough and understanding enough of how science works so that you can trust the information you're getting. And we are getting a lot of information at this point in time around COVID-19, all different kinds of treatments, vaccinations, mask wearing, social distancing. All those are independent, contributing things that should be tested and should be tested in the very best ways through randomized trials or full population, full treatment trials, which is another way to do good trials. And right now, we're not getting that. We're getting a lot of observational data, and the randomized trials we're getting are coming out fast under very trying circumstances and leaving some concerns about whether they're right at the end of the trial. So I hope this video helps you think through clinical trials. I'll see you next time.